its ups and downs. Turn your pretty face to an ugly frown. Seems that when I fix one thing.
Hello, welcome to The Awakening. I'm your host, Angela Brown. Today's topic for discussion, we're going to talk about senior citizens and health care, Part D. And I have a wonderful, wonderful guest today to share with you. His name is Councilman Trout, and he's going to be here. Hopefully, we'll give you a lot of information. If you need any more, just call back, and I can always do another show. So welcome, everybody. Welcome, Councilman Trout.
Thank you.
You look so handsome today.
Thank you very much.
You do.
Appreciate the compliment.
Oh, you're welcome.
Thank you very much.
I need to know what you've got to tell me on Part D. What is Part D?
Okay. As probably most of the folks that are out there that are watching this show, and even your seniors, they're familiar with the fact that they have to pay their doctor a fee, and then if they go in the hospital, they have to pay the hospital fee, and then when you get your medications, that's another fee. So the Part D is specific to prescription drugs, whereas the Part A and the Part B would be for coverage for physicians and also coverage if you have to go into a hospital to have a hospital procedure, something like that.
Okay.
So those are the three main components of
Now, I got a
Medicare.
question. What about a mom, a woman who's 65, okay?
Right.
She needs a mammogram. Would Part D cover her for a mammogram?
No, Part D is only taking care of the prescription drug part of it.
Okay, okay.
For a mammogram, then she's got to look at the Part A or look at the Part B because she's going to have a physician that's going to be involved and also a facility that's going to be involved.
Radiologist, yeah.
Right.
So Part A does one thing, Part B does another thing, Part
Right.
D does another thing.
That's right. That's
You need a
exactly right.
Philadelphia lawyer to straighten this stuff out.
Well, you do, and with the new law that came into effect, the healthcare initiative that was passed a couple of years ago, you have the new law, and it's called the Affordable Health Care Act. And
Affordable health care? Okay.
Right, and they go by ACA.
ACA, okay.
Right. And this is part of the prescription drug bill and also the health initiative that was passed at the federal level. So this is a federal program, and it's designed to try to help seniors specifically with regard to the prescription drug plan. And what they want to do is reduce the cost, the out-of-pocket cost that seniors have been paying. So just go over to another slide here and just give you some information about Medicare Part D. As I mentioned before, it's a prescription drug plan, and what they want to do is to provide coverage to the Medicare beneficiaries. And you really have to be in tune with the various providers because the government, although they are managing the plan, if you will, they actually do not have physical inventory as far as medications, drugs, etc. So what they would do is they would go to somebody who is a pharmacy benefit manager for them, go to a health insurance company.
Pharmacy benefit man?
Right, pharmacy
what does that
benefit.
mean?
It's the person who's actually responsible for the formulary. And that would be the pharmacy benefit manager. And the pharmacy benefit manager could be Blue Cross Blue Shield, it could be Humana, it could be Aetna. A number of different companies out there have various programs, and they have various tiers and various levels. So they all work together with the federal government, and the federal government does not tell the beneficiary, the patients, who to select. It's up to the patients to try to make a good guess or a good educated guess, if you will, based upon looking at what each one of the various companies offers, because they offer different things.
Okay, like what?
For example, the doctor may write for one particular branded medication, but that branded medication is not on formulary A.
Okay.
It would be on formulary B. So there are going to be differences in the formularies between the various pharmacy benefit managers. And then also, as far as the donut hole is concerned, and the donut hole.
What's the donut hole?
The donut hole is, and that's a real good one. Everybody really needs to be conscientious of the donut hole.
The donut hole.
The donut hole, according to the Centers for Medicare and Medicare Service, which is CMS,
CMS?
CMS, that's the,
Okay.
the initials for it.
CMS. Okay.
The donut hole phase of your Medicare Part D coverage begins when the total retail drug cost reaches $2,930. That would be your copays.
Oh my goodness.
Okay, so when you reach $2,930, you're now in the donut hole. You say, well, what happens in the donut hole?
Yeah, what does happen?
In the donut hole, you pay a higher premium, higher cost for the
Medicare?
medication.
Because it's Medicare?
This is Medicare Part D.
Okay.
You pay a higher cost for your medications when you're in the donut hole versus when you're out of the donut hole. And I'll give you an example.
Okay.
The donut hole, it ranges from $2,930 all the way up to $4,700.
Oh,
That's the donut hole.
Okay.
Now, in the donut hole, let's say a patient has medication that they want to get the medication. Well, the medication under the new plan, the affordable health care, now, because it's 2012, the patient pays 50%.
Oh.
Prior to that, the patient paid 100%.
Well, that's better.
Right, it's better. And
So
what they're
let me
trying
ask
to
you
do.
this. If it's a $100 prescription, does the patient have to pay $50? We say 50%?
Right.
Oh my gosh. 'Cause, you know,
Right.
I'm not going to mention the drugstore, but David needed some medication, and I went up and it was $171.
Right.
And I looked at that man. I said, have
Right.
you got all your, up here, you okay?
Right.
He just looked at me. So I went home and told David, and he said, here, I'm going to call them up. So come to find out, that was confusing to this man. He ended up getting it for $2.69.
Right, right.
So if I hadn't have gone bonkers,
Right.
And made a big fuss,
Right.
I guess it would have just been $171.
Right, and this is one of the things you really have to be cognizant and have
Yeah.
dialogue with your pharmacist.
Right.
A lot of times you have pharmacy techs that are filling the prescriptions,
Yes.
and the pharmacy techs, their level of information is not going to be as great as the level of information as your pharmacist.
Maybe we should have a couple of them in here today.
Right. but in the donut hole, what you have is they've come up with a new term, and it's called true out-of-pocket cost, and they also refer to that as TROOP. Now this is significant. The true out-of-pocket costs are your copays. Okay. And prior to the new law coming into effect, the Affordable Health Care Law, the out-of-pocket costs, when you got into the donut hole, you were responsible for 100% of the cost. Now, how you got into the donut hole is kind of amazing also. What you would do is you would go ahead and you would pay $5 for a prescription. That would be your copay.
Right.
But the medication would actually retail for, say, $75.
Yes.
Well, they would take the $75, and the $75 is what they would apply to putting you into the donut hole. So consequently, people got into the donut hole a whole lot quicker because they were using the retail factor of the medication as opposed to using the copay factor. And the copay factor is going to be much less. And the copay factor is the true out-of-pocket cost that a patient would pay for their medication. And they call that the TROOP. So that's a big change.
That certainly
big
is.
change in the way the prescription drug plans works now under the new affordable health care.
It's worse?
It's better.
It's better? Good.
It's better.
Good.
It's much
Yeah.
better. It's much better because now you're paying 50% as opposed to paying 100%.
My gosh.
And they're trying to phase it in all the way up into 2020, and this is the federal government. And when it gets to 2020, the goal is to not exceed 25% of the prescription out-of-pocket costs for the beneficiaries.
We really get the bad end of it, don't we?
Yeah, we
You
certainly
grow
do.
older and want to have a better life, and you have to wait to die because you can't really pay for your medications. I've talked to many people like that.
Right.
Many people who come
Right.
to me and talked about that.
Now, there are some things that you can do.
Well, in my estimation, you're a genius.
Okay.
You know what you're doing, and I trust you.
All
I
right.
trust you.
Now, this is something that I've been doing with my mother for at
Yes,
least
your
2-3
mom's what,
years.
89?
She's 85.
85. Oh,
And I've
don't,
been-
I'm sorry. Don't they call her 89? Okay.
And I've been doing this with my mother for about 3 years. Remember now, the donut hole. We don't want to get in the donut hole.
You don't
because
wanna
we're
get in the
gonna
donut
We're going to
hole.
pay more money in the donut hole than we do outside of the
Okay.
donut
No
hole.
donut hole.
So you have branded items, branded prescriptions, and you have generic prescriptions.
Yeah. What
Okay.
about that?
So for the generic prescriptions, instead of me going and using my mother's policy, her Medicare policy, I would use a store policy. And in this particular case, I used the CVS policy.
And what is that?
CVS policy gives you a copay, and the copay is pretty much similar to the copay you'll be paying with a lot of your plans on the Medicare Part D program. But using the CVS program, or if it's a Giant or Walmart, if you're using that particular program. Kmart is another
and
one.
And Walgreens is another big one.
Walgreens is another one. You generally have a lot of the different chain supermarkets, they have individual plans if they have a pharmacy. And by using this, you're not impacting your insurance. So consequently, the cost that you have for the generics is not being applied to putting you in the donut hole.
Right.
So when I enrolled my mother into the CVS plan, maybe about 3 years ago, there was a $0 cost. I've checked with CVS now, they charge $15 as an enrollment fee. But the $15 could be well worth it, because if you're getting
$1,000 worth of medicine?
Right.
Really?
Right.
Oh.
See, because you can save, and here again, it has no impact. Your insurance company does not know that you're getting this particular prescription.
Really?
So it has no impact on putting you into the donut hole a lot quicker. Okay? So that's one way where you can take advantage of using an in-store program and not going against your own insurance company.
In-store program.
Right.
Okay. And the donut hole.
Right. Now, looking at the donut hole, in 2009, as I mentioned, the beneficiaries, when you were in the donut hole, you paid 100% of your medical costs until you got out of the donut hole. In 2010, they paid 100%, but the patients received a $250 rebate. 2011, you got 50%, and it moves from 2013 to 2020. It's gradually going to decrease. And here again, the goal is to try to make sure that the beneficiaries do not have out-of-pocket costs in excess of 25%. Okay? Generic drugs is the same scenario. You'll see that in 2009, you paid 100%. In 2010, you paid 100%, but you got a $50 rebate back. And in 2011, you actually paid 93%.
Oh.
Okay, instead of paying the 100%. Now, from 2012 to 2020, there's going to be a 7% decrease per year. So for a patient who's in 2012, right now, since last year they had a 93%, that was the percentage they were paying, they pay 7% less, so they're paying roughly about 86% until it goes down.
Okay.
And here again, the goal, as far as the federal government is concerned, is to try to make sure that the out-of-pocket cost does not reach more than 25%. So that's the goal.
Now, what happens if someone, say they're 80 years old, but they don't have money to even pay out a copay? How do they get their help?
Well, we'll talk about that a little bit later on, because I do have some sites and I do have a telephone number that you can call.
Let's go.
So you can get some free medication.
Right, okay.
Okay. Now, here again, this is just a recap. They're trying to phase in, this is phase 3, in the federal government with the Affordable Care Act. They're trying to phase it in so that they can close in the donut hole, reduce the donut hole, and reduce the out-of-pocket cost to beneficiaries. And that out-of-pocket cost, they call it the TRUP, which is True RX out-of-pocket costs.
Okay.
So for your generic drugs, you're going to see a reduction all the way to 2020, and then also for the beneficiaries, will try to get it down where, here again, they do not pay more than 25% of the cost.
Oh my goodness.
Now, this next slide is kind of busy, but there's a lot of good information on this next slide.
You're here, this is your show.
Okay.
It's for the people, you do whatever you want.
Now, if you go to the second paragraph, this is really showing you how the donut hole works and giving you an example. Example, in 2012, a patient receives a 50% discount. This is on branded formulary medications. So the patient, the retail cost would be whatever the cost of the retail, the patient would pay 50% less. Now, this is a good feature in this particular, with the 2012, the way they have the Affordable Care Act. In order to get you out of the donut hole, because in the donut hole, you're in there between $29,300 and $4,700. So when you get out of the donut hole, you can either go into a catastrophic phase, or you can go into another phase, which is the last phase of the donut hole, where you're probably going to pay 5%.
5%.
5%
Okay.
of the total medical cost. So in order to get you out of the donut hole, they've made a change. Now the true out-of-pocket cost, what they will do is you'll pay your true out-of-pocket cost, but they're going to give you credit for the retail portion of it. And the retail portion is much more than the true out-of-pocket cost. The true out-of-pocket cost is your copay. So once you get into the donut hole, by giving you credit for the retail portion of it, as opposed to giving you credit for the true out-of-pocket cost, you're actually going to move out of the donut hole a lot faster.
Okay, so it's better not to be in the donut hole.
Better not to be in the donut
Better
hole.
not to be in the, okay.
Right. Okay.
Uh-huh.
And in 2012, anyone reaching the donut hole, as I said before, they'll get a 50% discount on all branded formulary drugs and 14% on all generic formulary drugs. Now, it has to be formulary. And here again, remember,
what does that mean?
Formulary means that this is the drugs that the pharmacy benefit manager says that the patient can get off of a list of approved drugs for that particular plan. Think of that as being a formulary.
A formulary, okay?
Formulary, okay. Each one of the plans has their own formulary, and there can be different drugs on the formulary because you have different drugs, different agents in various classes. Like you have antihypertensives, so they could go with antihypertensive 1 on one particular plan, and they can choose another one on another plan, okay? Now, one of the things that, as I mentioned before, you'll get out of the donut hole, and once you get out of the donut hole, you either go into catastrophic phase or you're going to go
What
into...
is a catastrophic phase?
That means...
It sounds like a hurricane or
well,
an
that's
earthquake.
exactly what it means.
It means it's really bad.
It really is really bad.
I'm glad.
That's what it means. It's
okay,
really
it's bad. Okay.
So basically, what you're going to wind up doing under the Affordable Health Care Act is paying about 5% of your total prescription costs once you get out of the donut hole. I'm just going to mention this just briefly. There's another set of patients which a lot of physicians really don't know about, and these patients are called dual eligible patients.
Dual?
Dual. D-U-A-L, eligible patients. And a dual eligible patient is a patient who's a Medicare patient, but their family income or their individual income is very low. So they're at the federal poverty level. And
what about someone on welfare? They would be...
That would be someone who could be dual eligible. So in the dual eligible patient, this patient who's qualified for Medicare would also qualify for Medicaid.
Oh,
And
what's the difference?
Well, Medicare, you can get on Medicare if you have a disability prior to 65.
Okay.
And the Medicare, the Social Security system was set up way back when for patients to assist citizens rather, once they turn 65. So when you turn 65, and actually your Social Security Administration really wants you to go down 3 months prior to your 65th birthday so that you can register for your Medicare benefits. And your Medicare benefits would be your A, your B, and your D. Your doctor, the hospital, and also your prescription drug plan. So that's what you're going to register for.
Okay.
And they want you to do that 3 months prior.
Is A what?
A, you're talking about your doctor's portion.
Okay.
B, the hospital portion of the bill. And D is the pharmacy portion of the bill.
That takes care of you then, doesn't it?
Yes, it does. Okay.
Okay.
So those particular patients there, they're able to, because of their low income, they're able to qualify for being dual eligible, and they can get benefits from both plans. And what I did was on this next slide, this just gives you what the guidelines are for 2012, because they'll change from year to year. But these are the most recent current guidelines for 2012, and it's for the 48 states that are contiguous and also the District of Columbia. There's another set for Hawaii and another set for Alaska. But this is for the 48 contiguous states, as they are also refer to as the continental United States.
Okay.
Okay? And if you look under 300, we're going to come back to that row here that has 300.
Okay.
Because there is a plan in the state of Maryland that if you are at 300% of this poverty level or below, you can qualify for another plan in the state of Maryland, but we'll come back to that.
Yeah, okay.
All right, let's talk about a couple of tips.
Okay.
Some of the tips that you should always use is when you go to the doctor and the doctor is putting you on new medication, you should always ask the doctor for some samples, especially if it's a branded medication. No need asking for generic medications because the pharmaceutical companies do not supply generic medication samples of generic medications, and generally at the end of the life cycle of a branded, just before it goes off patent, you'll start to see a decline in the number of samples that a pharmaceutical company will also share with their physicians. So if you're going to the doctor and the doctor is going to see you every 4 months, and the doctor puts you on a new medication, ask the doctor, can I get a month's
samples?
Can I get a month's worth of samples? Because I don't know if I'll be able to take this medication.
Exactly.
And we always say in the pharmaceutical industry, the most expensive pill that you have is that one that's sitting in that medicine cabinet that you can't take. Okay, that's the most expensive one. So that's another way where you can actually save money. If you're getting a refill, you know that you've already been on the medication, so you know that you can take the medication. You may want to ask the doctor, okay, can I get a couple of weeks?
Right.
But if the doctor's putting you on a brand new medication, you should be asking for a month's worth of samples.
A month? Okay.
A month's worth of samples, okay? Also, splitting pills. Splitting pills is another way that you can actually save money. And some of the pills are actually very easy to break. One of the big branded items out there now, which has just gone generic, is Lipitor, which is called a atorvastatin. It's a cholesterol-lowering agent.
That's what my husband is on.
And so my mother, she was taking 40 milligrams of Lipitor once a day.
Oh, my.
And her cholesterol got better, so the doctor dropped her down to the next strength, and the next strength is the 20 milligrams. So instead of getting 20 milligram prescriptions, and I had some of the 40 milligrams, basically what I did was I bought a pill cutter, and I would take the 40 milligrams, put them in there, cut them, and so I'd have a pill cutter.
That's
to
wonderful.
do that.
You're
so I
very-
actually saved quite a bit for out of a 14-day period. I actually saved out of a 28-day period. I actually saved 14 tablets.
That's good. That's
Okay.
very good. You're very smart. You know
Oh,
that.
thank you. Thank you.
I'm enjoying being here with you. I really am.
And so that's one way you can do it. Also, a number of tablets are scored. And I didn't bring a scored tablet with me. But if a tablet is scored, the best thing to do is to put it down on a flat surface and just to use these two fingers and go at the opposite ends of the pill where it's scored and just press down with both fingers. It'll break right in half.
Really?
It'll break right in
Okay.
half. If it's scored, a number of the pills are scored. Now, if you have some smaller pills that are not scored, don't worry about those. Don't mess with those. But some of the pills are large enough, like a atorvastatin, that it's very easy for you to do it in a pill cutter. And then you have some other pills which are scored, which means it has a little mark in the middle of it so that it can break very easily. Okay? So that's what we're talking about, scored pills.
Okay.
Okay? Now let's get back to what you were talking about, patient assistance. The first two bullet points, I've taken those from a book. It's a book that was authored by my uncle, Universal Healthcare in the United States, and I have a chapter in the book, and my chapter is called A New Era in Pharmaceuticals. And this is some of the information that I have listed in my chapter in the book. And it's a patient assistance program. It's a 800. It's a toll-free number, 888 number, and it also has a website. And I called it yesterday, so it is.
It's up and working.
It's up and working.
Okay.
And then there's the second bullet point. Montel Williams, not recently, but over the last 2 to 3 years, especially when the Affordable Health Care Act was being discussed in Congress, you saw a lot of vignettes of Montel Williams, who's a Navy SEAL, ex-Navy SEAL.
And he's very sick too. He's very sick.
Right. He would come out and he would give you some information on where you could go to our website. So I have that particular website, which is listed in the second bullet point. Now, the third bullet point is something. And looking and doing some research on this was a program that I was totally not aware of, and I found it by going through the CMS website. And CMS, remember, that's the Centers for Medicare and Medicaid, and that is located up in Security Boulevard up in Baltimore. That's where they have the main office for it. So I saw this particular program. It's called the Senior Prescription Drug Assistance Program, also known as SPDAP.
SPDAP?
Right,
Oh
SPDAP. They always have some sort of an acronym with a lot of these different medications. This is a Maryland program. It's a state of Maryland program.
Yay,
and this program was
yay.
established by the Maryland General Assembly in 2005 to provide financial assistance to, get this now,
Okay.
moderate
Moderate.
income family Maryland residents. Moderate.
That's amazing.
So not low income, but moderate
Okay.
income Maryland residents. And let's just go back to this slide that we were talking about. If you look at the 300 level, on that 300, if you're at 300 and you're going left, going to 200, 100, 133, or 100, that means you qualify for this particular program here in Maryland. And let's see if we can find it. Here we go. And this is the patient assistant program. And the eligibility requirements are you have to be a resident of Maryland for at least 6 months, be a Medicare recipient, and have an income at or below 300% of the federal poverty level. And that was that column that we showed you.
Yes.
And you can see for one person, that salary was roughly about $34,000. So if the person made 33, whatever it was, 33,500 or less, they would also be able to qualify for this particular program.
That's wonderful.
And get some assistance. Because
Okay.
we say, well, why would you want to do that? The reason you'd want to do that is going down to the fourth bullet point when we talk about gap coverage, donut hole subsidiary.
Okay.
Remember, currently, right now, you're going to pay 50%.
50%. Okay.
Okay. If you're in this program, you pay 5%.
Oh my gosh.
So it's a big difference on the amount of money that can be saved
Right.
just by being in this program.
I have a question for you.
Sure.
We're running low. Is there any way you could come back next week and pick up part 2 on this?
Well, we got the end. I got the end right now. This
You
is
got the end? Okay,
This
go
is the
ahead.
last slide.
We have a couple minutes.
Okay. Basically, what I've done is provided some sources where you can go, and you'll have the contact
Yes.
information. So there's places that you can go with security, for the Social Security Administration.
Right.
You can go to the Centers for Medicare and Medical Services. I also have the contact person here, Tracy McCutcheon, and her 410 number. And then there's also the patient assistance program to get free medication. So there's a number here as well.
You
on
are
the website.
fabulous. You know that.
Okay.
You're very
So I hope
good.
this information has been helpful.
so.
And as I said, the law is still evolving because the Affordable Care Act, it's still going, and the cutoff points as far as where they'll stop it is 2012. So
Okay.
you still have different parts of it that are coming into play
Okay.
up until 2012.
This has been a wonderful half hour.
Okay.
It feels like just a couple of minutes, but I've
Okay.
learned so much.
Okay. All right.
You're very good. You're aware of all of this, and
Right.
just a lay person would know
Right.
what you know.
And
you
just one caveat is 2020, not 2012. 2020.
2020, okay.
Right, 2020.
And this
not
got you started because of your mom.
Well, I've been in the pharmaceutical business for almost 30 years.
Oh, okay.
So I had the background in pharmaceuticals, and so I understand this. But a lot of it, by taking over the responsibility of medicines for my mom, and I pay for all her medicines. I
You're
make
really
sure
a good son and a
I
smart man.
put her medicines. I fix them up every Monday or every Sunday for the week.
Right.
So
I want to thank you.
thank you
I have
so much.
had a wonderful, wonderful 30 minutes. I hate to see you go.
Thank you very much.
I hope all of you are getting what we've already showed you today. I mean, I feel so different inside myself. And I want to thank all of you for watching, and I want to thank you, Councilman Trout, for being here. Until next time.